Button is not wanting to work.
Oh, there we go. Okay.
There we go. My apologies. Hello, my name is Crystal Cohens, and I'm the Director of Clinic Partnerships and Business Development for the MAVEN Project. Thank you all for joining us today and our friends at Manic Community Health Center for hosting today's session titled Evaluating Palpitations. My apologies. 1 second here. For attending our session today, does your patient with palpitations have an arrhythmia with Dr. Charles Schulman? Dr. Schulman was an assistant clinical professor of medicine at Harvard Medical School from 1988 until 2016. He is currently a corresponding member of the faculty of Harvard Medical School and recently retired as a senior physician at the Beth Israel Deaconess Medical Center in Boston. In addition, he has been practicing non-invasive cardiology since 1970. Dr. Schulman's scientific articles and abstracts have appeared in the New England Journal of Medicine Circulation, the American Journal of Cardiology, and the British Health Journal. His research interests include the treatment of hypertension, congestive heart failure, and hyperlipidemia. Thank you, Dr. Schulman.
Okay. Hello. Good afternoon, everybody. We will talk about a relatively common symptom and just what its meaning is or can be. I have no disclosures, nor does anybody else that has anything to do with this presentation. And as already stated, the MAVEN Project designates this for 1 hour for a one CME credit hour, category 1. So an outline of the talk will be something like this. First, we'll talk about the definition. The definition of palpitations is the awareness of the heartbeat. There are important aspects of the history, including symptoms and red flags, the diagnosis by cardiac monitoring, and then some specific arrhythmias that one might see. And finally, when to refer to electrophysiology. So we can start off with a case. This is a 76-year-old asymptomatic man who comes in for his yearly exam. He has no exercise limits, no personal or family history of heart disease, and he doesn't take any medication. His exam and labs are normal. His ECG shows normal sinus rhythm, is otherwise normal, except that there's one PVC, premature ventricular complex. Not contraction, incidentally. Contraction is a mechanical event, and PVCs are electrical events. So which of the following is the most appropriate management? Perform a cardiac MRI, order an exercise ECG, begin metoprolol 25 milligrams daily, or reassure him. If you want, you can put in your answer in the chat. Let's see if that works.
We have a response from Elizabeth Maxwell, reassurance.
Okay. Okay, and someone else says the D. Okay. Fine so far, and we'll get back to the answer after a bit. What's this? Okay. All right. So there are a number of arrhythmias that cause palpitations. The most common and really mostly benign arrhythmias are premature atrial complexes and premature ventricular complexes, PACs and PVCs. Other common arrhythmias include atrial fibrillation or flutter. Atrial fibrillation is the commonest arrhythmia that we see in clinical practice, that you see in clinical practice, that the cardiologists see in clinical practice, and that the electrophysiologists see. Paroxysmal supraventricular tachyarrhythmias, AV nodal reentry tachycardias, ventricular tachycardia, and then bradycardias and heart blocks. So, considering the history, what you need to try to determine is whether the onset of the palpitations are sudden or gradual, whether they're momentary or sustained. That is, how long do they last? How often do they occur? What triggers are there? Or are there any characteristics or medications or activities that trigger the arrhythmias? And then whether there are associated symptoms like breathlessness or chest pain or dizziness or actual syncope. There are a number of red flags that you need to think about. Sort of at first is consider the red flags. If a patient has either pre-syncope or syncope, particularly if there's an injury from the occurring during the syncope. I had one example of a fellow who had a syncopal episode and broke his nose, for example. That's the kind of thing I'm talking about. Whether or not there's chest pain or shortness of breath, whether there's the new onset of an irregular heart rhythm, whether the heart rate is fast or slow while at rest, whether there's underlying heart disease, and the family history is important. We'll talk a little bit more about that later. So there are a number of types of palpitations that can relate to the clinical presentation. So the first type is what are called premature beats or extrasystoles, PVCs or PACs. The patient will describe a skipping or missing a beat or heart sinking. The heart may be irregular, interspersed with a normal heartbeat. The onset would be relatively sudden rather than gradual. Tachycardias are often described as flutters, although atrial flutter is a specific arrhythmia, but this term flutters is usually is often used to describe any kind of tachycardia. The heartbeat may be regular or irregular and markedly accelerated. The onset may be rather sudden. And some associated symptoms are listed here, as we've talked about before. Some palpitations are anxiety related, described as either anxiety or agitation. Here, the heartbeat is regular, maybe slightly accelerated. The onset is gradual, the offset is gradual, and patient may also complain of tingling hands, lump in the throat, or sighing dyspnea. And then another type is just the feeling of a pulsation, which again, palpitation is the sensation of your heartbeat. And here, we're talking about your heart pounding. Would be regular, possibly normal frequency, or more rapid, especially during physical effort. These are some clinical characteristics of palpitations due to tachycardias, due to actual tachycardias. So again, atrial fibrillation, the commonest one we see is irregular, variable heart rate, by its nature, a variable heart rate. it can occur at any time, either with physical effort or cooling down, but alcohol intake is an important trigger. Um, uh, uh, AV reentry tachycardia or AV nodal reentry tachycardia are have sudden onset. They're regular. The heart rate is rapid and perfectly regular. Uh, 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 Atrial tachycardias and atrial flutter are similarly described. And then monomorphic ventricular tachycardia is noted with an elevated heart rate, may or may not be related to physical effort. And what's important here are signs and symptoms of hemodynamic impairment. The effect of vagal maneuvers can help to differentiate these one from another. With atrial fibrillation, vagal maneuvers can transiently reduce the heart rate, as it can with atrial tachycardia and atrial flutter. With the reentry tachycardias of AV or AV nodal reentry, the vagal maneuvers will cause sudden interruption of the tachycardia, and I'll explain why. Vagal maneuvers will have no effect on ventricular tachycardias. Did I have? So, no. Okay. All right. So, when one considers clinical features of your patient in the diagnosis of arrhythmias, then there are a number of clinical features which may be suggestive that the palpitation is of an arrhythmic origin, such as heart disease, an abnormal ECG, a family history of sudden death, especially at a relatively young age. It's often said that people who just drop over suddenly have had heart attacks, but in fact, that's probably an arrhythmia. Usually, heart attacks have some symptom preceding the sudden collapse. Advanced age and hemodynamic instability are also important clinical features. In terms of, some things will tend to rule out clinically significant arrhythmias, including a short duration of the palpitations and perhaps a history of panic disorder. Okay. There are a number of ECG findings, which may be suggestive that palpitations are of an arrhythmic origin, including ventricular pre-excitation. We'll talk about that. P-wave abnormalities, PACs, sinus bradycardia or atrial fibrillation, ventricular hypertrophy, long QT interval, and AV block or bifascicular blocks. So, when you have a patient, when you encounter a patient who complains of palpitations, there are a number of questions to ask. What are the circumstances prior to the onset? What are the circumstances at the onset? And what are the circumstances at the end of the episode? Right? Was there what was his or her activity, position? Is it abruptly? Did it start abruptly or slowly? Did it end abruptly or slowly? Was it preceded by other symptoms such as chest pain, shortness of breath, and dizziness? Did the episode end spontaneously or with some vagal maneuver or some drugs? On a background and some background information as well. Right? What was the age at the first first episode? Whether there were previous episodes and the frequency, whether there's previous cardiac disease, whether there's previous psychosomatic disorders, whether there's a family history of cardiac disease or tachycardias or sudden cardiac death. What medications was the patient taking at the time of the palpitations? Is there drug abuse? Or would there be a reason to suspect electrolyte imbalance or potassium disorders? Now, how you one of the first things I advise people and advise my patients is that if they're having a palpitation and it doesn't show up on the resting electrocardiogram that we've just taken in the office, then we need to try to document the arrhythmia, and that can be done in a number of fashions. There are event recorders, which will record an event if you push a button, or this is the device, sort of a handheld device. You put your fingers on here, and it records an ECG. This is a smartwatch. This is a Holter monitor, right? This is named Holter. Is named after Jeff Holter, who developed this, what he called radio electrocardiography, or recording of ambulatory ECGs. The original Holter monitor was a huge backpack, like the backpacks that astronauts have. But of course, the devices have become much smaller than that. And these record for 24 to 48 hours. The modern version of that are these ECG patches, which can record for 7 to 14 days. And then there are the implantable loop recorders, a very small device that's probably an inch long and several millimeters thick in a cylindrical fashion that's implanted right under the skin, with a 10-minute procedure that can record for several years. In addition, nowadays, all of the pacemakers or the pacemaker defibrillators have recording devices, and so they record every heartbeat while the device is in place. So when would you want to get an ambulatory ECG monitor? Well, if there's a very low risk of concerning arrhythmias, then I wouldn't bother. If you're talking about unsustained palpitations, well tolerated, you find a few atrial or ventricular premature contractions. I almost made that mistake. Complexes, a few PACs or PVCs on the ECG, so you have an idea of what the arrhythmia is. If they're unsustained, well tolerated, patient has no evidence of heart disease, then it's not necessary to do monitoring. If there's a higher risk for concerning arrhythmias, then yes, you should do ambulatory monitoring. Palpitations that are sustained, poorly tolerated, or associated with syncope or pre-syncope are situations that would call for that. If the patient has organic heart disease, status post-acute MI, cardiomyopathies of any cause, clinically significant valvular disease or hypertrophic cardiomyopathy, or if there's a personal or family history of arrhythmias or of syncope, sudden death, cardiomyopathies, or the long QT syndrome. If your patient has frequent symptoms and associated syncope or heart failure or acute myocardial infarction, then of course inpatient evaluation is the thing to do. So the flow chart would look something like this. If the history, physical exam, ECG show a definitive or suspected diagnosis, then confirm the diagnosis and treatment if necessary. If there are still unexplained palpitations, if there is no heart disease and a normal ECG, and they're rare or well tolerated, no need to do anything else. On the other hand, if they're frequent or severe, or there's heart disease, then a workup is indicated and treat the arrhythmia as needed. So let's talk about some specific arrhythmias. The commonest one is atrial fibrillation, as I've already stated. This is a nice illustration of the difference between sinus rhythm and atrial fibrillation. This shows the conduction system as normally operated, or as normally operational, I should say, giving you sinus rhythm on the ECG. On the other hand, in atrial fibrillation, there were upwards of 360 impulses per minute that bombard the AV node, some of which get through, some of which penetrate, some of which get through, others don't. Depending on the amount of penetration and the amount of refractoriness, the rhythm will be more or less irregular. So here is a 64-year-old woman who has palpitations, and here is her electrocardiogram. The question is, this arrhythmia, well, what is the arrhythmia, and which endocrine disorder is it most consistent with? Hyperthyroidism, hypothyroidism, hyperparathyroidism, Cushing's disease, or Addison's disease? Why don't you share your results in the chat? 1, 2, 3, 4, or 5.
We have a few responses stating that the answer is 1.
That's saying that the answer is 1, and that is right. What's the arrhythmia? Of course, is the arrhythmia. Of course, is a atrial fibrillation. Rapid, irregular, narrow, complex. You can guess that it's atrial fibrillation, and it is. Okay, and of course, this can be associated with hyperthyroidism, and if you treat the hyperthyroidism, the arrhythmia will go away. Okay, and just as a quick summary of what's in the latest American College of Cardiology, American Heart Association guidelines for atrial fibrillation. These are the pillars for AFib management. Okay, so address and treat stroke risk, optimize risk factors, and then symptom management, including rhythm control or rate control, and consideration of what's called the atrial fibrillation burden, which is the amount of time that you're actually in atrial fibrillation. These are the risk factors that should be treated in order to minimize atrial fibrillation. But there are a number of lifestyle strategies that people don't really think about that are beneficial in reducing the burden of atrial fibrillation. Significant weight loss for obese patients, regular moderate physical activity, exercise, CPAP, use of CPAP for more than 4 hours a night for those folks who have sleep apnea, and a reduction in alcohol consumption, and certainly reduction in binge drinking, which has been known to trigger episodes of atrial fibrillation. Okay, so here's a 33-year-old woman who complained that her heart skips a beat. And what you see is some pauses, and you see what looks like sinus rhythm over here. And is this heart block? Yes or no? Heart block, yes or no? Put it in the chat. Heart block, yes or no? Okay. The answer is no. And I'll get back to exactly what it is. Here's a 54-year-old woman who complained of palpitations, and here we have a rapid, perfectly regular tachycardia at 150 beats per minute. And the tip-off to what this is that little blip in V1 that looks like it might be a funny looking right bundle. The blue arrows show the same thing in leads 2 and 3, and they are actually retrograde P waves. This is AV nodal reentry tachycardia. So let me take a moment and talk about what reentry is. In the AV node, and there are other situations where this type of thing gets set up. In the AV node, there's a fast track. There are two pathways. There's a fast pathway and a slow pathway. The impulse comes down from the atria. It travels rapidly down the fast pathway, travels slowly down the slow pathway. But by the time the impulse traveling down the slow pathway gets to this point, it's already refractory. And so what you have is a single transmission of the depolarization and normal sinus rhythm. If the fast pathway is blocked, then the impulse travels slowly down the slow pathway. And by the time it gets here, the fast pathway can accept, is not refractory. And so the impulse travels retrogradely back up the fast pathway and sets up this circular or reentry cycle. And in the AV node, I think here illustrated right here, you see the reentry circuit. Okay. And there are the retrograde P waves sitting in the middle of the ST segment in lead V1. Okay. Here is an AV-NRT, AV nodal reentry tachycardia, started by a PAC. So there's sinus beat, PAC. Okay, travels down the slow pathway, back up the fast pathway, setting off this tachycardia. And you can see the retrograde P waves. You don't see them real well here. Here you can see them a little better here. But you notice that when it converts to sinus rhythm, you don't see that little blip there. See? There's no blip there. Okay. And incidentally, to answer a previous point about what happens with vagal maneuvers, if you interrupt or you change the conduction characteristics of any part of the reentry circuit, the arrhythmia stops. So that's the mechanism there. The frog sign is the contraction of the right atrium against the closed tricuspid valve, giving prominent jugular venous distension. That's what the frog sign, and makes you look like a frog. Okay. Now here is a 20-year-old woman who complained of palpitations after a run. On exam, her blood pressure was 125/80. Her pulse was pretty fast. Her exam was otherwise normal. And here's this wide-looking, irregular tachycardia. Do you know what this is? Is this ventricular tachycardia? The answer is no. Looks like VT, polymorphic VT. Well, not really. A rapid, wide complex tachycardia that's irregular is likely to be atrial fibrillation. And the cause of the atrial fibrillation in this young woman was seen after she was cardioverted back to normal sinus rhythm. And what you see is she has a positive arrow sign. That's what I call it. There's a wide complex with a slurred upstroke and a short PR interval. And this is the WPW, or Wolff-Parkinson-White syndrome. I'll show you here. This is from the Wolff-Parkinson and White's original article, nicely illustrated. Short PR, there's the delta wave, and a wide QRS complex. Okay, and so what's going on is that here's normal AV, normal transmission, right? The impulse goes from the sinus node to the AV node, down the bundle branches, his Purkinje system. And WPW, or pre-excitation, there's a bypass tract, like over here. And so here you have a normal PR interval and a narrow QRS. Here you have this slurred upstroke delta wave and a short PR interval because the transmission is so fast and it bypasses the AV node. And so you can have two kinds of AV reentry tachycardias with the reentry circuit as follows. The impulse can go down the AV node and back up the bypass tract, giving you a narrow complex, or it can go down the bypass tract and back up the AV node, giving you these delta waves, these wide QRS complexes. And I think I can show you, you see, so here this is traveling down the bypass tract. That's what's going on here. Okay. And here are doctors Wolff-Parkinson and White. Dr. Paul Dudley White was widely regarded as the founder of preventive cardiology in the United States. He was one of the founders of the American Heart Association, and was an advocate for healthy living, and riding a bicycle. Here he is riding a bicycle along the bike path along the Charles River. If you're familiar with Boston and the Charles River, this is from the Cambridge side. That's the city of Boston. This is on the Boston side. The bike paths they're named after Dr. White. Okay, so here is a 73-year-old man who complained of palpitations and lightheadedness. And he has a rapid rate, it's 150 beats per minute. And you'll notice that there are these negative looking things in leads 2, 3, and AVF in a so-called sawtooth pattern. And here you can see in V1, there are two P waves. There's one there, one there, one there, one there. So there's 2 to 2. The conduction is 2 to 1. Okay, so this is atrial flutter at 300 beats per minute with 2 to 1 AV conduction, as shown here. All right, now turning to another source of palpitations. We have this 33-year-old woman who complained of palpitations and had these funny looking beats, FLBs, as you'll see. FLBs, funny looking beats. These are PVCs, as you can see. She had a large amount of them, but they were of low grade, and her echo was normal. Well, the computer thinks this is atrial fibrillation, but it's clearly not. Right? This is not atrial fibrillation. Okay, so when you see funny looking beats, what you have to try to determine is whether they're ventricular in origin or supraventricular in origin, PVCs versus PACs. So PACs can be either conducted, like so, or non-conducted, like so. So if we go back to that other tracing, here, you see, is this heart block? It's PR. Yeah, PR. Premature P wave. These are non-conducted PACs. Right? These are PVCs that here they're occurring in bigeminy every other beat. This is trigeminy every third beat. This is a couplet. This is called ventricular tachycardia, 4 beats in a row. So here's a 56-year-old man with hypertension who has coronary disease because he had a previous stent. Complained of palpitations. His blood pressure was 105/65. He was perfectly alert, and the exam was normal. And here's his ECG. And what does it show? Well, it shows a wide complex tachycardia. And the question is this ventricular in origin or supraventricular in origin? Well, it's got a right bundle branch block appearance, and the axis in the frontal plane is what we call northwest axis, or right superior axis. It's in this quadrant over here. Okay, and so as I say, the differential diagnosis is between ventricular tachycardia and supraventricular tachycardia with abnormal conduction. Okay, the differential diagnosis goes something like this, right? If you have an unstable patient with a wide complex tachycardia, treat that patient as if he has VT until proven otherwise. Okay, then if the patient is stable, is the rhythm regular or not regular? If it's irregular, greater than 90% of them are AFib, or possibly polymorphic VT. If it's perfectly regular, it's monomorphic VT in over 80% of patients. That's why you should assume that it's a VT, especially if the patient is unstable. What is the QRS axis? I think Showed you that before. If you have this so-called northwest axis, that's highly suggestive of ventricular tachycardia. Is there AV dissociation? That's also suggestive of ventricular tachycardia. Here in this illustration, the lines are P waves, and you see that the atrial rate is slower than the ventricular rate. This is what's called a capture beat, narrow complex beat in the midst of a wide complex tachycardia. These are called fusion beats because they're somewhere in between. Is there a history of heart disease or arrhythmias? And if so, it's likely to be VT. Kind of simple as that. Okay, here's an example of ventricular tachycardia with fusion and capture beats. So the P waves are the red arrows. And this is a capture beat, narrow complex. As you can see, it looks like the same as the sinus rhythm over here. And the fusion is somewhere in between. So that proves AV dissociation, and that proves that the wide complex rhythm is indeed ventricular tachycardia. And so this is indeed ventricular tachycardia. That's what this is. So here's a 68-year-old woman who complained of shortness of breath and palpitations for a week. Her past history is that of hypertension, chronic kidney disease, and she has known coronary disease. And here's her arrhythmia. You can't measure the rate. It's greater than 100. It's irregular. It's narrow complex. There's only one thing that this can be, and that is what? The answer is atrial fibrillation. Right? Somebody. AFib, right? AFib. You're right. You are right. Okay, so. Oh, come on. So she's anticoagulated. She's cardioverted to sinus rhythm and feels great. 6 months later, symptomatic AFib recurs, and she's given Sotalol, 80 milligrams twice a day, and cardioverted again. Again, she feels well, except that she has 2 syncopal episodes, and this is what her ECG looks like. So the question is, given this ECG, what is the most likely cause of her syncope? Sick sinus syndrome, monomorphic VT, torsade de Pointes, recurrent AFib, GI bleeding, or a stroke. What do you see? What do you see here that gives you a clue to all of that, to the cause of the arrhythmia?
Feel free to type your answers in the chat.
Are we getting in there? No?
I think everybody's shy.
Huh?
I think everybody's being shy.
Okay, well, that's okay. What's obvious here is that the QT interval is prolonged. Oh, somebody answered. QT is too long. Right. Exactly. That's exactly right. This is the difference between a normal QT, which is less than half of the RR interval, and a long QT, which is more than half of the RR interval. And here, I mean, this goes from here to all the way over here. You see, so that for sure is a prolonged QT. And of course, what is the cause of her syncope? The answer, torsade de Pointes, torsion of the points, from down to up to down again in the same lead, which happens to deteriorate to ventricular fibrillation. Fortunately, she was cardioverted, or she wasn't cardioverted, she was defibrillated. I don't know the follow-up after that. So there are a number of risk factors for drug-induced torsade decline, which is why I point this out to folks. Because I'm concerned about, I'm concerned, and you should be concerned about the drugs that we prescribe. So, right, yeah. So the risk factors are a long QT to begin with. Over 500 milliseconds is kind of the threshold. Patients who develop what I call the three hypos: hypokalemia, hypomagnesemia, hypocalcemia, the use of QT prolonging drugs, the concurrent use of more than one QT prolonging drug, heart disease, heart failure, etc. And this is a very short list of drugs that pose a risk of torsade. The actual list is a page and a half, single space. I mean, there's a long, long list of drugs. But amongst the antiarrhythmic drugs, they're so long right there. Okay. But antibiotics are going to be more commonly used by most primary care practitioners. And so you need to be aware of this. I ought to put azithromycin in here because that's a commonly used one, much more than clarithromycin, for instance. Antidepressants and some other drugs, including methadone, hydroxychloroquine, danzadrone. So just be aware of that, and especially when you have more than one drug that prolongs the QT. All right, and I think this is the last case. This 81-year-old man came in confused and stated that he tripped over a rug. And here you have what looks like polymorphic VT. Except, what's the cause of the polymorphic VT and what's the treatment? Well, the cause of the polymorphic VT, we got an answer. Okay.
Thick sinus.
Thick sinus. I don't think so. Because look here. Here's the sinus rate. 300, 150, 175. Sinus rate's is 60 or a little bit less. It's actually somewhat variable. No, this is high-grade heart block. This man needs a pacemaker. Is what the treatment is. He needs a pacemaker. So one of the causes of polymorphic VT is extreme bradycardia, which is what you see here. Here you can't see. I mean, this is an extremely slow rate. Oh, here, if this is a native beat, then from here to here, I don't know, a 4-second pause. So this person needs a pacemaker, and this illustrates that symptomatic bradycardia is a good reason for a pacemaker. So, what is the treatment for ventricular arrhythmias? Well, if they're single PVCs, the first thing to do is try to document it if you need to. And then reassurance, as we said in the very first case, if there's no heart disease and they're infrequent. If they're frequent and bothersome, you can consider a beta blocker. For non-sustained VT, that's a different story. Monomorphic VT, if it's short duration, 3 or 4 beats, you probably don't need it, or 4 to 6 beats or something like that. You don't need any treatment. A beta blocker might be indicated if there's left ventricular dysfunction or sustained VT with coronary disease and or left ventricular dysfunction, then an implanted defibrillator is indicated. And then the treatment for polymorphic VT, if it's due to well, the initial treatment, as in our patient who developed torsade after Sotawall, it is magnesium, IV magnesium, and removing the offending drug. But these are more complex and really need cardiology help. So, when should you refer to your friendly electrophysiologist? A complex patient, or one who requires an intervention like a pacemaker, or a defibrillator, or an EP or an electrophysiologic study, or consideration for an ablation procedure for either atrial fibrillation, ventricular tachycardia, or extremely frequent PVCs. So the teaching points that I would point out as a result of this are that palpitations, especially in young, healthy people, are most often brief and benign, and you don't really need to worry about them. But watch out for red flags that might indicate more significant arrhythmias. Certainly document the arrhythmia if there is any, and then treat or refer as necessary. And my parting shot is right there. This comes from the New Yorker.
That's hilarious.
I'll let you think about that, right? This is from the cartoon caption contest, right? Another suggestion for this was, I left my heart in you left your heart in San Francisco. Thank you very much.
Awesome. Thank you so much, Dr. Schulman. That was an amazing presentation. I have two more questions from one's from Lena Batista, states, how do you test for arsenic and what are the sources? And does insurance cover arsenic testing?
Arsenic. I think testing hair and nails, I believe, is how you test for arsenic. And I don't know if depending on what the insurance is, would cover that. But if the insurance covers all other tests, I don't know why it wouldn't cover that. What's the other question?
She wanted to know what is the best diagnosis code to use when testing for arsenic. And she wanted to thank you for talking about heavy metals.
I didn't talk about heavy. Oh, okay. I don't know the answer to that one.
Okay. Are there any more questions that we have from the group? She said it was on one of the slides that you covered.
Yeah. What's the question?
About heavy metals.
Is that right? Could have been. Could have been. Just a second, I'll take a look.
Okay. Let me see if she knows which slide.
It's probably up here somewhere. Heavy metals? Really? I don't know, but okay. Here? No. No.
Okay. She
Sorry.
is going to I'm going to unmute her.
Okay.
Hang on 1 second, Lena. And get back to the chat. Now I'm having difficulty opening up the
Well,
unmuting her.
oh,
My apologies.
that's okay. I'm, you know what? Uh, uh, give her my email address and let her send me an email. I have to leave because I have another teaching session at Beth Israel.
Well, we'd like to thank you for your time today. And I just want to send everybody a reminder to ensure that you complete the CME survey that will appear in the tab when you close out this webinar. We really appreciate you taking time to complete this. And I hope everyone has a great day.
Oh, I see. Oh, I see. I see there's a question here about anticoagulation in atrial fibrillation.
There's one more question. For patients with intermittent AFib occurring infrequently every few weeks for a few hours at a time, how do you decide when to anticoagulate?
Okay, and the answer is I depend on the CHADS-VAS score. So you need to calculate the CHADS-VAS score. In a younger individual whose score is 0, no anticoagulation is necessarily indicated. If the score is 2 or greater, then yes. So a person who's over 65, who's hypertensive, who's diabetic, that's 3. Okay, if they're over 75, that's 2 just right off the bat. But that's how I decide. Score is 1 in a 68-year-old male. That is less clear, Doug. It would depend on whether that person, what that person's other risk might be. But if a score of 1, you can either choose nothing or choose to anticoagulate.
Well, hopefully that answered everyone's questions. Again, we'd like to thank Dr. Schulman for your time, and we hope everyone has a great day.
Okay, thank you. Bye-bye.
Thank you. Take care.